Welcome to the Emergency Mind Podcast. I'm Dan Dworkis, and this is a space where we train ourselves to think and perform better during times of crisis. ER doctors or not, we all face emergencies in our lives, and this podcast is all about getting better at acting during times of uncertainty and stress and learning how to apply knowledge under pressure. So listen up, train hard, and enjoy, because you never know what's coming your way next. To learn more about building your emergency mind and to dig deeper into many of the concepts we get into in this podcast series, head over to our website at emergencymind.com. This episode is an interview with Dr. Erik Anderson. Erik is a board-certified emergency doctor and an attending ER physician at the Department of Emergency Medicine at the Alameda County Medical Center Highland Hospital in Oakland, California. He received his medical degree from the University of Minnesota and then did his residency in emergency medicine at Alameda County Medical Center Highland. After residency, Erik did a fellowship in population health and social emergency medicine at Stanford University, and then went to New Mexico to work for the Indian Health Service as the chief of emergency medicine and trauma medical director for Northern Navajo Medical Center in Shiprock, New Mexico, which is where I was lucky enough to meet him. Erik is truly an awesome dude, and I'm very happy to have him on this podcast. We cover a lot of ground in this podcast, talking about running a rural emergency department with limited resources but an important mission, about the idea of acting quickly during the beginning of an emergency, and about the importance of compassion for handling yourself under pressure. As always on this podcast, our mission is to dive into applying knowledge under pressure, not to provide specific medical advice. Additionally, our opinions are our own and not those of our respective employers. All that said, let's get to the episode. I hope you enjoy. Erik, really happy to have you on for this and to get a chance to talk with you about this. I know we've worked together in the past, both on research projects and in the emergency department, and I'm really happy you agreed to come in and talk to me about this today.
Yeah, I'm excited to be here. Thanks for inviting me. It's my first podcast, so I'm really nervous.
Welcome. You're doing great so far.
Thanks.
Excellent. I figured we could start with a case that the two of us worked together basically the first time we ever met, which was like the first day that I came to join you all, and almost the very first case of the day, which was a person that had been involved in a bike accident and had some pretty serious trauma. And I'm wondering, do you remember that case?
Absolutely. Yeah, very vividly.
Excellent.
It was literally the first case of the day. I think it happened at 7:04 or something like that in the morning.
Right. And so I was obviously an ER doctor at that point, but I was brand new to the system and brand new to the community. And this is, you're sort of orienting me to the system. And what was going through your head when we were doing that? When you have a scenario where there's a potentially sick person and you have a team that you don't really know, you're trying to get used to, and that maybe doesn't understand the context of how to practice or how to work under emergency situations in your context.
It's sort of an interesting thing to have happen to you, like to have a really critical patient on literally your first several minutes of being in a new emergency department. It was such a different experience for me being there, at that point, I think at least a year, mm-hmm. and being the medical director. And so it didn't, it felt like a big moment, just mm-hmm. because it was like a sick guy. We don't have the capability to care for this guy at our hospital, right? And it was different for me because I knew everybody on the team. I knew sort of like the processes for how to do things. So I think that was probably more stressful for you because everything was so new. When we're talking about this, emergency mind and thinking, how do you think clearly under pressure? This was one of those situations where I think it was a little bit different for me because I knew the steps that needed to happen to go, how to take care of this guy. To be honest, it was also just great to have another person there because I was used to being completely by myself the whole time. That was a sort of an extra bonus for me. But I do remember that case. It was just kind of a bizarre way to start your career where you were working, right?
Right, exactly. In that context, the ER doctor is often totally alone and sometimes is the only doctor in the entire hospital. And so understanding how to run a case within that particular context is really important. And so there's the idea of sort of developing systematic knowledge, right? Like how do you understand how to execute a plan in a particular place? Mm-hmm. And then separate from that is sort of the idea of how do you how do you execute a plan when you're the only person who's there capable of doing it? When you came out of residency and went out to work in this environment, what was that like for you at the beginning when you were learning how to practice totally on your own like that?
Well, I'm not sure that I knew exactly what I was getting into, to be perfectly honest. I think that in general, we know the steps that need to happen to care for a critical patient. We just don't always know how to execute them. And in a new environment, if you're by yourself, if you don't have a trauma surgeon or a trauma team for someone with blood in their belly, you know the steps, but it's very different if you're in a smaller place. And so the first couple times where that happened to me, we had a critical patient, still sort of like you just try and remember those steps that you need to take. And I think you just have to try and prepare yourself to spend an extra few seconds listening to somebody else about how a certain thing happens, right? Most of the time, if you're going to go to a new place, we're talking about the emergency department, right? Like a good analogy or a good example is like the clerk or the charge nurse or some nurse who's been there for a long time probably knows exactly who you need to call. And I think it's easy to get caught up in like, oh, do we have 2 IVs? And like, do we have blood here? Do we have platelets here? That kind of thing. And it takes a second to sort of stop and listen and be like, what do we do in this situation at this hospital? Which is something I think like you were really good at also. But I think like going to a new place like that, I think that you just have to have this sort of open mind and the humility to listen, even when it's really stressful. And that always for me has been like the key to trying to maintain some type of composure when it feels like things are out of control, is sort of relying on your team and knowing your team, right? That particular case we were talking about where this guy comes in like critically ill 4 minutes into your shift, like you didn't even have time to like introduce yourself to everybody, I don't think. But that was the first thing I did when I got to small rural ED, try and make sure I knew everybody's names, and who had been there for how long and who seemed like they knew how to get a patient out of there fast if they needed to. And gosh, there's so many people who know how to do that, right? Like here we are coming from this like big city, big training program, and we think that we have like this amazing skill set, which, I think that anyone who's board certified in emergency medicine has got a great skill set. But you go to a smaller place and you think like, well, I'm, maybe you feel like you're bringing a lot of expertise to that area, but man, there's a lot of expertise that already exists there. They've been taking care of patients for a long time.
And there's the idea too of how do you map your knowledge into this particular situation. And so you mentioned the idea of staying extra open to input from other people, particularly people that have been in that situation before. Was there anything specific you did at the beginning to try to shape the way that you think like that?
I've always felt like the most important characteristic of an emergency physician is humility. It just helps in every single situation, but especially when you're trying to manage sort of like really stressful circumstances. So like the really practical thing, I think, like I was sort of mentioning, is like trying to get to know every person as soon as possible and kind of get a sense of how long that they've actually been there for. I think getting to know those types of people and that I think is a really important thing. You sort of have to like go into that situation and realize that you're the new person, and despite whatever you think about yourself, you really are going to have to rely on so many people to get the job done.
In addition to the people and the system, was there anything you did differently internally in your sort of setup to the approach of a case when you find yourself in this smaller rural emergency department?
One of the things that I tried to do was think about things that I could do quickly and immediately and things that I couldn't. And I sort of needed to remember to step back and take a couple extra seconds or a couple extra minutes to figure those things out. So there was a co-resident of mine who I trained with, named Matt Kiefer, who would always talk about like fast tests and slow tests in a code, right? So like you have your iStats or whatever is a fast test, or a POCUS is a fast test. And then your slower test would be like your CT. And I think that sort of expands when you're in these situations where you don't exactly know your surroundings, is that that there's certain things you can do. Like you can make sure that you get 2 IVs in and you can send the appropriate initial tests. You can still do your like fast tests. And then I think it's important to remember that, hey, now I need to step back and just take that like extra minute that I wasn't used to taking because I'm by myself and I don't have a trauma team standing next to me, and trying to like sort of figure out those next steps. I knew that I would need to be patient and open to the extra few minutes that I wasn't used to taking. Those are the things I think were really important being, by yourself, managing, we had some really sick patients there, right, Dan? I think like those extra couple minutes of, either asking for help or asking the team around you, wait, what do we do in this situation exactly? And being sort of bringing yourself to that place where you're ready to sort of listen more often than you would have otherwise, I think is the key.
And so the idea is you're almost describing two sort of phases of an event, right? Like the hyperacute phase, it's like your first minute of the case where you're sort of making sure that you execute a couple of key skill sets. And then you take a second, you pause, you go into this other kinetic where you're a little bit more contemplative and you slow down your thinking and try to make sure that you do the next couple steps right.
Yeah, definitely. I think about like when you listen to some podcasts or something like that. And always the first step is IVO2 monitor, advanced airway equipment at the bedside. Like that's just like a thing you say on a oral board prep, But I think when you're actually in those environments, you're actually by yourself and you're actually trying to manage a sick person. There literally are just a few things that you can do immediately that make a really big difference. And then you have to just be like, prepare yourself that you're going to have to step back at some point and troubleshoot something that you weren't used to having to troubleshoot.
Yeah, and let's dive into that a little bit. So what does that mean to prepare yourself to troubleshoot something?
I think it's like walking in there and be like, I know that I'm not sure exactly where every piece of equipment is going to be that I'm going to need today. Recognizing that fact, I would suggest that like the main thing is to be like open to the idea that you're going to have to be ready for uncertainty. And walking into that shift, you're like, man, this is going to be something I don't know how to deal with today. And I'm going to I need to like remember that that's okay. I can breathe and step back and think for a second. Because I think we get into these routines, especially if we're used to a certain circumstance, right? Like if it's just like cranking out patients or whatever, that we kind of like have our algorithm set up. And I think we don't always go into shifts in the emergency department with the idea that we're going to have to be flexible for that day.
And this idea of needing to slow down in order to turn on other systems of the brain and needing to slow down in order to get to a correct answer that you might not be able to see if you're just bulldozing through everything is really important. And I think that's one of the things that personally I find so interesting about emergency medicine is that we have these two speeds of thought, right? There's fast first and slow second that we sort of kick on afterwards. There's this great, I think it's a Wyatt Earp quote that says, you got to learn to be slow in a hurry. Which I think is really applicable to that. And when I look back at some of the people that I was training with that were really sort of master at resuscitation, I always watched them do this, and they seem to have this really like preternatural ability to identify when you had to move fast and when you could move slow and which was the appropriate speed to it, what the rhythm was to it. Does anybody stand out in your mind as having that ability particularly and that was involved in your training?
Oh, yeah. I mean, I can think of some great people who were always, had that humility, had that sort of like openness to other people's opinions and be able to slow down when it was necessary, especially when things got stressful. It's like I'm thinking of Jocelyn Freeman Garrick, who was one of my attendings at Highland. Like she would always sort of like seemed to know exactly what was going on. But as I've observed her a little bit more and been around her more, sort of as a colleague too, I do sort of see her like take that step back and like absorb and then be like, okay, this is what we're doing. But one thing that you kind of brought up before, or that you alluded to, was like that resuscitationists are that was where we sort of recognize that skill set. But when I think of that with Jocelyn, for example, like I think of when the department's blowing up or when we have a tough disposition or something like that, like those are sometimes some of the more stressful situations where maybe we don't have like one or two critically ill patients, but we have like 20 moderately sick patients, or we have someone who we just cannot figure out what needs to happen for them. We're talking to multiple different consultants or multiple different hospitals and trying to get, this is what we get placed in these situations, right? We're trying to get someone else to help take care of this patient. And that can be extremely stressful. And I think, how do you prepare yourself for those tough conversations with consultants, or how do you prepare yourself for trying to sort of like exude that calmness, or that like, let's all just take a step back for 1 second. Maybe it's only 1 second, and that's going to help everybody when you're dealing with, 6 or 7 nurses in a busy department, for example. And so I think that it's so easy to talk about these examples when we're talking about critically ill patients. But
Mm-hmm.
I think some of the most stressful parts of our job, or some of the most intense pressure parts of our job, are not always with sick patients. Speaking of our experience in our rural emergency department, I can think of several examples where some of the most stressful experiences for myself and my colleagues were trying to transfer patients, and
Mm-hmm.
no one would take them, and it's maybe the appropriate, someone had a bed, but the person you're talking to, it didn't feel like you got across why they needed to be transferred, or why your colleague at our institution felt like that patient needed to be transferred. And so I think that being this sort of idea that I'm going to have to like go into my shifts and be able to step back under pressure or under stress and calm myself down so I can accomplish my goal applies to some of those situations as well.
And so do you think that it's the same or a different set of skills that you marshal when you have different types of pressure that you're facing like that?
I sort of feel like I feel like they're similar, and maybe I'm wrong here, but when I'm imagining myself in these difficult conversations or circumstances that are like more indolent, I feel like the ability to sort of like, it's almost like I'm talking myself down, like I need to sort of just be like, okay, time to take a step back. Maybe that's just like a pause or a deep breath, or like I have to go get a cup of coffee right now. Actually, that's what I really need, but the sort of openness to those brief interventions for yourself is what helps. And I think a lot of those circumstances, obviously you can't get a cup of coffee if someone has blood in their belly, but you can if like you're between conversations trying to transfer a patient for 4 hours.
So I was listening to I think it was one of the MCRIT podcasts with Scott Weingart not too long ago, where he was looking at techniques that come from the aerospace fighter pilot sort of world. And he was discussing the idea of something that sounds very similar to what you're talking about, which is the idea of a tactical pause. The idea that sometimes taking a step back, and this is something you see in martial arts, you see all sorts of the times that like driving forward consistently isn't always the only way to do it, that sometimes you need to take that half step back and regroup yourself to continue. Do you have other than get a cup of coffee when you can, do you have anything that you tend to use for a tactical pause? Any sort of a mantra or an anchor point, or what do you do to take that pause?
Let's take our examples of trying to transfer patients, or trying to deal with consultants, or trying to get someone to help you take care of somebody in a remote place, right? Mm-hmm. As our example better. I get that example. I get this like analogy of like a tactical pause. I feel like in medicine, it's helpful for me to think of it more as sort of an interpersonal thing. And that means instead of talking about like tactical or aerospace or something that like it's personally is like a little bit harder for me to relate to, I try and think about like empathy or compassion or refocusing on the patient or something like that. And so the thing that I always think of, this has stuck with me since med school, was we had I think it was a psychiatrist, gosh, this is so long ago, where he said that everybody is trying their best considering their circumstances, right? And I think that like whenever I think of that idea, that like literally everybody around me, I truly believe is trying their best. Everyone has different circumstances, so maybe that doesn't always seem obvious. That always helps me when I'm trying to talk to a patient and that's not going well, or I'm talking to a consultant and that's not going well, or things are really busy and I feel like I need to sort of like organize my team to accomplish a task. Is like sometimes it really just helps me to sort of do that sort of pause where I'm just saying everyone's doing their best and that's all anybody can do right now, and we're going to keep doing our best. But that really just helps like reset me in my mind when I get into these sort of like interpersonal things that we run into all the time, right? Because our jobs are always about people,
right?
And I think reminding ourselves that this patient is trying their best. Given their circumstances, this patient is absolutely trying their best. That just like helps me reset and be like, okay, let's like work together. It can reset a conversation. It can reset a conversation with a patient or a consultant or other members of your team, a tech, a nurse, or whoever in the ER.
Right. So you're obviously way nicer than I am, which I love.
I don't think that's true though.
But functionally, I mean, I really like this idea of believing that we're all in this together, right? And that's something I try to do and work with my residents to do as well, which is that we're all on the same team, which is to try to get the knowledge to this patient that needs it. And when you do that, when you find yourself in that pause where you're revisiting the idea of everybody doing their best. Just for 1 second, I want to deep dive on that. What does that look like? Do you stop talking and take a breath? Do you like walk out of the room if you can? Like, how do you actually physically make that switch?
Oh, absolutely. Yeah, I think that there has to be something physical about how you extract yourself from that situation. Whether that's, if you're on the phone sitting in a chair, that means you to get up for a second, or if you're in a room with the patient, maybe you do have to step out for a second and come back again. It's so hard to, like you're talking about bulldozing ahead. Like you can't reset if you just continue to go. And so I do think that there's something physical about that deep breath or that like exit from the room where you can recognize and have that self-awareness to be like, something's not going right now. What is that about? I need to remember everyone's trying their best, kind of thing. It sounds a little bit cheesy, I guess, but just sort of like recognizing that. I truly believe that, like, everybody does try their best considering their circumstances. And I think that really just helps. And however you do that, if it's like you said, walking out of the room, getting a cup of coffee, having some chocolate,
Right on.
I think you have to recognize that moment and then do something about it that's physical. That's been the key for me, at least.
Yeah. And how do you recognize that moment? Is there a thing that you feel in yourself? Is there, do you have, some like systems running in the background to try to ask yourself, hey, am I getting, am I on tilt here? Am I getting swept?
Well, I think that I think we all recognize those moments, right? Where we're like, I'm so irritated right now, or like I'm so upset right now, and we feel that. It might be hard to extract ourselves from that moment. It might not happen immediately, but I think the idea that like something's different right now about how things are going. It's not going well. I'm feeling this way, and then taking that moment and be like, okay, I got to just step away for a second. Everyone's trying their best. I guess I don't know how you get to recognize that moment earlier, because I guess earlier is better, maybe, as opposed to like maybe that's been going on for an hour, right? But like whenever it happens, it happens. Sometimes it doesn't happen, right? Sometimes it's like your shift's been over for 4 hours and you're like, oh yeah, everyone was trying their best. Then it's not that helpful.
Yeah, that's interesting though. So you're sort of saying that whenever you recognize it is the time to get to work on it, and which is one skill, which is you recognize you're being sort of swept or taken or there's the Buddhist idea here of this thing called Shempa, which is being pulled by a thought. So you recognize it, and then you have your systems to try to address it and reset to your natural state, which is, hey, everybody's trying here and we're all on the same team. And then sort of separate from that is like learning how to recognize it on the earlier side of the spectrum, so you don't make a mountain into a molehill, so you don't get continually swept by this sort of same stuff going on. I wish I had a wonderful answer to how to do that earlier. I'm not sure I do off the top of my head, but something to work into or to look into for sure.
Yeah. Hey, we're all trying our best, right?
Exactly. And I think, you said this a minute ago, which is that, we don't practice emergency medicine doesn't happen in a vacuum, right? We don't just sit in front of a computer and press a button in order to try to deliver some knowledge. It happens in the real world, and that real world involves people and interpersonal relationships. And so understanding how each of us interacts with people, not just in a broad sense, but in that moment on that day, is a really important part of our ability to deliver this knowledge when it's needed. And coffee is very important, for instance, right? Like having that is really important, and doing whatever it takes the day before to set yourself up for success for your shift. I don't know. Did you work on that in residency? I remember that being a thing I was struggling with, especially at the beginning. With how do you eat? How do you sleep? How do you set yourself up for success like that?
So I trained at Highland Hospital, and we always had GI rounds. GI rounds was like lunch, right, or dinner or something like that. So there was always a time where we would have GI rounds, and it would be somewhere between like around a typical meal time. When we try and all sort of get to a point where we could take like a 15-minute break and eat. So it was sort of built into the structure of training that recognition that everybody does need to sort of step away for a second and eat, right? Like I've heard this before about residents or docs who are nurses, whoever, like who are like, I didn't eat today. I'm like, man, that's a problem. Like you got it. How can you like, I think that like addressing some of those like basic things that like human beings need help you, or recognize those moments when things are stressful, or do some of these like things that we're talking about that don't always go so well to sort of manage a difficult situation. If you haven't eaten in 8 hours, like, man, it's gonna be really hard to recognize that moment. You're just gonna like keep bulldozing forward, being super hungry, and then all of a sudden the end of your shift is gonna come and be like, man, what happened there? It's like, well, I probably should have eaten lunch. Sometimes things aren't as that complicated. It's like we just got to eat a little bit.
I think all of us at one point or another have been through a shift where you look back and you're like, whoa, like, yeah, what just happened right there? Maybe I should have eaten lunch. Yeah.
Exactly. Yeah. How many times did it happen?
Right. We're these very sophisticated, well, you more than me, sophisticated physicians, but we also, you need sugar to fire your neurons.
Yeah.
And you need the ability to have the space and to have the structure you need to be able to make good decisions.
Mm-hmm. Yeah. And we can talk about all these other sort of like mental tricks or preparation, but you got to eat,
I want to go back for 1 second to something you mentioned earlier, which was, again, this idea of the fast test and slow test, which sort of gets to the idea that there are things that you need to do and act on right away, and other things you can take another second and think through. When did you start sort of teasing out the difference between those things, and how did you learn that?
I specifically learned this idea from Matt Kiefer, who's a great guy. I think that like some of this comes with practice and just experience, right? Like just like any of these skills that we're talking about. Like I can remember specific cases where I was completely freaked out, and then I remembered that I just had to like use my bag valve mask, and then I could take that second and do it. But like that quick recognition by either myself or RT or somebody, right? Like that really just need to sort of do a quick thing like a bag valve mask, or we've all had that patient where like, why are they acting so weird? And then like someone's like, hey, did you check a glucose? And you're like, oh yeah. So I think like some of those things come with practice and with time, but I do think at this point in my career, I'm like 4 years out of residency, I think we've had enough cases where that really quick thing stabilized the moment and stabilized not only the patient but the room. I can think of a case 2 weeks ago where it was just like super sick kid, and all of a sudden like you do the bag valve mask and you can take a second, and everybody sort of like calms down because that like medical stabilization intervention also stabilizes the room, right? Same, we all know that feeling, like we were talking about the glucose, right? You check a glucose and it's 20. And everyone kind of relaxes because they like know how to fix it now. This quick test, fast test idea is something that I think we all can relate to in emergency medicine, or whatever we're doing, that there are sometimes quick things that allow a stabilization period where you can then step back and do some of these other things we're talking about.
And do you think that the calmness and the space that comes with doing those actions, do you think that's a factor of removing uncertainty from the equation? We talk about with my residents a lot the idea of you have this complicated, very difficult, very uncertain sort of situation, and one of your first jobs is to break it into component pieces that are simpler. Does this person need an airway right now? Yes or no? Does this person need a breathing tube right now? Yes or no? Or a chest tube? Yes or no? Those simple, easier to decide sort of moves. And part of that seems to be about uncertainty. I don't know if that rings true for you.
The glucose example, like the low sugar, that is removing uncertainty. Everyone's like completely calm, but like the really sick kid who's apneic, who you bag, just because they're like not hypoxic anymore, doesn't remove the uncertainty of like, how and when should we intubate this kid and what the heck is going on in the first place. Like, so I think that, obviously removing uncertainty allows that period of stability. But I also think that just remembering that you can take, sort of like you were saying, right? Like those like incremental steps in management that, some being fast and critical, if you can execute those things, like you might still have uncertainty, but at least you can, when you have a sort of a stabilization period, you can try and think a little bit more clearly.
And Erik, how do you train folks in these ideas?
I don't. I wish I had a great answer for that. I think we just have to model good behavior, and we have to expose trainees to volume, to be getting experience with sick patients and letting people manage those situations, as being sort of like the leader in the room, and debriefing and giving feedback. Gosh, some of these like really critical resuscitations. To be honest, I'm not sure I consider myself an expert in that area. But these stressful situations with patients and difficult dispositions, it's like thinking of another attending who would always be like, okay, we don't know what to do. Let's just go back to the bedside. And like, has that ever failed you? No, I don't think so. And I think like reinforcing some of those behaviors with residents, be like, I'm not really sure what to do. Like, let's go back to the bedside. So I think there's specific like little things you can do clinically, like going back to the bedside, or thinking about things in terms of fast tests and slow tests. Yeah. Otherwise, I wish there was like a good way to. I'm not sure that I know the answer. I struggle with this every day still.
Both you and I, in our current primary roles, both see patients and supervise the training of emerging ER doctors who are going through their residency. And so this is a really salient issue, which is not just sort of how did I end up in this place, but how do I create an environment and a structure which helps the next generation of doctors sort of get better at this than I am, and absorb these concepts and put them into play quicker.
And one of the things for us, like I think, like you said, we both have similar job descriptions, I guess, right? Continuing to see a decent volume of patients on your own, I think, is really helpful, right? Like going through these challenges and practicing clinical emergency medicine regularly is, I think, important because we learn every single day, right? Like it's crazy.
Yeah, you were saying a few minutes ago about how you go on to a shift and you go in with the realization that there's going to be something that I don't know today. And I think that humility, that humbleness is very real and very true, which is that you walk into basically every shift with the idea that there's going to be something that's an incredible challenge that, I'm going to have to figure out on my feet. I'm only a few years out. My suspicion is that sense won't go away. But also, interestingly, that it's not just sheer numbers of exposure, right? It's not just the integral of patients over time, because I think that as I look at the people that brought me up, that trained me, there's definite differences. All of them are competent, skilled, board certified ER doctors, but there's also the ones that sort of stand out as the paragons about being really, really good at delivering this type of knowledge under pressure. They must be doing something different in their training, in their careers, that got them to that point. I think all of this is a skill, and you might start with some ability of it, but it's a skill that can be trained and developed over time. Is there anything that you generally recommend for your maybe a senior level medical student or a beginning resident or something like that? Any book, any podcast, anything that you recommend for folks to get started with on this sort of a journey?
Gosh, I wasn't expecting the part at the end about like other resources, because I was thinking of attendings who sort of like shaped me, like Caitlin Bailey being one of the attendings at Highland, who would tell a senior medical student, like, what are the 3 things that you need to do? You need to work hard, remember what the vitals are, and don't lie. Like those are the only things, right?
That's good.
But I think I do think that there's something about like values and behaviors and how you think about and treat people that can reinforce some of these other sort of tricks we've been talking about. Like we're talking about like, how do you stay calm, or how do you respond to pressure? Most of our conversation, I feel like, has been about like people and empathy and humility. Those are things that I think that we can teach people, and I think that we can't forget to teach those things as part of our training, and we're talking to people who are students or residents or whatever. Man, is there something other than outside of medicine that I think has been helpful? Like for me, like exercising, like running, So I think everybody's got to kind of like find their own thing.
Those other attendings that you've seen really lead the way in this, is there anything else specific that they do or that maybe you've adopted?
There's all these like little mantras. I think the Carter Clements was like this Highland legend, and he would always just say, like, if you don't know what to do, be a dumb, diligent doctor, and just like go through those steps, order that extra test if you're not really sure what's going on, kind of thing. So I think that was always helpful. But I think like modeling these like earnest, genuine curiosity type of behaviors that are patient focused, those are the things that I've walked away with for sure as being some of the most helpful things. I think of other attendings, like Doug White's another one who would be, just like genuinely wanted to know what the patient's story was. What exactly did they say, which is just like, I think, so helpful in trying to figure out what's going on. It's like, you just have to be like genuinely and earnestly interested in what someone has to say. And again, like, these are sort of like behaviors and values and, ways we approach interpersonal interactions, more so than learning how exactly to intubate a patient. Those are the things that I found the most useful, I think, especially in some of these other environments where you might be by yourself.
When you were starting to take over the ER in this small rural place, and all of a sudden, you went from finishing residency to really being the leader of a team and of a department. How did that type of pressure manifest itself, and how did you deal with that sort of higher level of pressure?
That was a difficult part of my job, like I was a year and a half out of residency, and you're supposed to like be in charge of this group of people, some of whom have been doing emergency medicine for 20 years or more, and recognizing that they had a lot to offer in terms of their both like clinical and personal experiences, but also the institutional memory and knowledge of the place was helpful. Being open-minded to that. I think we were trying to make a lot of changes that, no one likes change that much, and the idea that we can try and redirect it to the patients was always like a really important thing about trying to do that. And I think that relieves some stress, right? Like we would have, I remember, very specific, many interactions with other providers or nurses about a specific thing that we were doing with department flow or policies, procedures, et cetera. Those were some tense discussions, but like and felt really, really stressful. But when we could sort of like regroup and reorient that idea to improving patient care, everybody genuinely wanted to improve patient care, no doubt about it. That helped me to remember, and that helped, those conversations to sort of like redirect and say like, this is why I think we should do this. And there might be some like, well, let's do it slightly differently, or maybe we shouldn't do that. And I think that was always helpful. But I think sort of like refocusing what the priorities are for a discussion, redirecting that towards the patient, I think was always that helped a lot. Didn't help every time, and I wasn't able to do it that well every time, but I think that was when we were able to feel like there was some successes. I think that was part of the special sauce,
Right, to get everybody on board with what the mission was, what the purpose is of what you're doing.
Mm-hmm. Yeah.
Nice.
Yeah, especially at a place like that where like it's so much about being driven by a shared sense of purpose. Yeah, how do you create that? Like, it doesn't happen in a short period of time, certainly, but I think you can try and remember those in some of these stressful situations of trying to do some leadership stuff.
Well, Erik, before we wrap this up here, is there anything that we haven't talked about that you think we should, or anything that you want to leave people with?
My main takeaway is what's always helped me is trying to always remember to be humble and to be compassionate with other people that I'm working with and also with patients. It doesn't sound directly related to responding to extreme pressure, but I think that's always what I always tried to do to get through those situations.
Right on, man. Thank you so much for joining me on this. Well, folks, it looks like I accidentally deleted the section of the audio where Erik said you're welcome and that he was happy to be a part of the podcast. That said, I hope you enjoyed hearing from him as much as I did. Thank you for listening to this episode of the Emergency Mind podcast. I hope you enjoyed it, but more importantly, I hope you found something in there that you can use next time you find yourself in the middle of an emergency. To learn more about what we talked about in this episode and about building your emergency mind in general, head over to our website at emergencymind.com. Thank you and take care.